Hello, I'm Dr. Omar Bey, and welcome everybody to OBHealthy's Doctor Lounge. We're so proud to be able to bring this webinar to you. And today we have a special topic, which is diabetes. Diabetes is one of those topics that we all need to listen to because even in my family, we had diabetes. So I'm going to learn something today as well. We have two major I say our focus has two major aspects. Number one, it's to see if we can educate people of African descent about health and doing better as far as their health is concerned. Number two is young Black males. We need you in medicine. If we're going to look at where we're going to be I'd say as a race, in 10, 20 years, it's going to be hard to find a Black male physician. So we need you to consider going into medicine. If you have any interest in science or anything like that, consider medicine. That's what we're asking you to do. All righty. Our webinar is every second Saturday at 1 o'clock. And you can come on and you can ask your medical question. The whole focus of this webinar is for you to get your medical questions answered. So don't hesitate. As we are here today and as we start, and we're going to start with a short presentation, put your questions in so that you won't, at the end, you won't be, trying to get them in and the webinar, ends before we get a chance to answer them. All righty. If you want to see our prior webinars, just go to OBHealthy, obhealthy.com, and hit our YouTube channel. All of our prior webinars are there. Okay. The most important thing that I can say today, and please understand, do not change any aspect of your medical care until your doctor, assesses what's going on. Only your private physician can truly take care of you from a medical standpoint. Okay. I think that's just about it for me. But what I want to say today is that this topic is one of those topics that we all should know about. And the good thing about it, let me just step back for a minute. The good thing, and I should say the greatest thing about it, is that we have someone talking about it, and he's one of our own physicians. We have somebody who's going to present and talk about it and educate you. And he has more experience than most as far as diabetes is concerned. He's lectured around the world, Africa, South America, United States, all about diabetes. So we have him here, and we want you to take advantage of this brother. He's one of ours. We're focusing on the topic that he bangs this topic. So let's get our questions in. Please get your questions in. Dr. Aluya, you know I'm talking about you. Please introduce yourself. You're on mute, Doc.
All right. Well, great. Thank you so much. Well, Nelson Aluya, medicine and pediatrics trained. Dr. Spratt will always ensure that I say that. So I always say I'm two doctors in one, trained in medicine, trained in pediatrics. I call myself first and foremost a medical advocate because that's what I do around the globe, talking about health and health-related issues as it concerns us as a people. And then I've been assistant professor of medicine at the New Jersey Medical School, Rutgers University, and also chief medical officer for the Newark Community Health Center. So I run a private practice. And my big interest and zeal is to ensure that our people are engaged, informed, educated, especially in the areas of health and everything health, but particularly diabetes, because it's I often say it's the bane of our existence. So and that's what we're going to talk about today. And I'm glad to be in the presence of these esteemed, other great intellectuals and luminaries, so we can have that discussion. I expect to hear all the questions today, and we can take all of them. Thank you.
Excellent. Dr. Court, you're next.
Dr. James Court, my practice is located in East Orange, New Jersey. Specialty is internal medicine. I treat only adults.
All righty. Dr. Clark.
Dr. Kevin Clark, surgical oncologist. I work at North Beth Israel.
All righty. And welcome, Dr. Ali. Dr. Ali, we don't hear you. We don't hear you. For some reason, no, your volume's not there and you're not muted. I don't understand why you're not coming through. Okay. Dr. Garrison, welcome. Welcome.
Hey guys, what's up?
Oh, hey, listen, you emailed me or texted me yesterday and said you were on the boat.
Well, the ladies were feeling uncomfortable. They thought it was raining too hard. I'm like, it's a gorgeous day. So if they're not uncomfortable, you don't go out because it'll be a miserable sail. You know.
All righty. Well, welcome. I'm so glad you could join us. This is a topic that we're going to get going. Dr. Aluya is going to start us off in a minute, but Dr. Ali had problems with his volume. Introduce yourself, please. Dr. Garrison?
Oh,
yeah.
Hi, good
yourself.
afternoon. Good afternoon. My name is Jordan Garrison. I'm a general and vascular surgeon. I specialize in diseases of veins. My office is in Hackensack, New Jersey. I train with all these guys. It's a pleasure to be here.
All right. Excellent. I'm going to tell you, we're going to start off with diabetes, and I'm just going to give some basic explanation here. Now, if you dial up or if you go to Google and say, what is diabetes, it's going to give you what AI, the first statement you're going to see is what AI puts out there. So let me just before Dr. Aluya starts, let me just tell you what I found. Explain what diabetes is. And we say, make it simple. And let's see if we can do this very simply. Diabetes is a chronic disease that occurs either when the pancreas is an organ that produces insulin, does not produce enough insulin, or when the body cannot effectively use the insulin that is produced, okay? Insulin is a hormone that regulates your blood sugar. All righty. Now, that's just a simple diagnosis of what diabetes is, but we're going to really get into it with Dr. Aluya right now. Dr. Aluya, do you want me to bring up the slideshow? But hold on, if Dr. Mazer Ali is coming on, there you are. Do you have a volume for us?
All right. Can you hear me?
We can hear you now. Can you introduce yourself, please?
Hi, yes. Good morning from California. My name is Dr. Mazer Ali. I'm a gastroenterologist at Scripps Clinic in San Diego.
Excellent. Thank you very much. Now, what I'm going to do right now is I'm going to bring up the slideshow for Dr. Aluya. We're going to get started, get some explanation, give him about, I should say, 20 minutes to really give us a handle on diabetes. And then from there, I want medical questions out there. I want you to ask your questions so we can get some knowledge going and get your questions answered. Here we go. Ready? Okay. Dr. Aluya, do you have control of that?
Okay.
Do you have control of it, Dr. Aluya?
Yes, you guys can hear me, right?
Yes, we can hear you. Go ahead.
Okay. All right. So, well, good afternoon, everybody. It's good to see you. Dr. Bay, I'm getting some texts here telling me that they're not giving access to some people want to join, and they're just texting me and calling me that they can't join in. So maybe somebody needs to pay attention to see what.
All righty. Just let me say one thing. Please go to OBHealthy.com. That's all one word. OBEY healthy. No, excuse me. OBHealthy.com, and click the doctors tab on top, and it will bring you to the page that you can register and come into the webinar. If you have a problem, please text us back, or they can text either Dr. Aluya or me, or put it in the question and answers and we will see it. Thank you. Go ahead, Dr. Aluya.
All right. So, well, good afternoon, everybody. It's good to see all of you. Um, and it's a pleasure to come talk about this disease that I call a pandemic now. As a matter of fact, it was actually called the pandemic before the pandemic. So people realized it was an epidemic, but because it's truly moving so quickly across the globe, it's becoming a pandemic. And I'm going to show to you, I'll give you a global perspective of what diabetes is, but not just that, but to also tell you how severe it is and why we must pay attention to this, especially those of us who are of African descent. So our learning objective today is to, see what the global etiology is, the risk factors for the disease, the trends of diabetes mellitus across the globe, the cost and burden of managing diabetes, the racial and ethnic prevalence of the disease, and then diabetes in the Black community, as well as collaborative strategies and objectives of managing the disease. So that's what we're going to be focusing on today as we move on. So diabetes, like I said, and Dr. Bay was just trying to explain, or describe, is a disease, is a chronic disease that occurs either when the pancreas does not produce enough insulin, and the pancreas is the organ that produces insulin right in the abdominal cavity on the left upper area of the abdomen, and if it's not producing enough insulin, then because insulin helps the sugar get into the body, so if it's not getting in, then the body cannot eat, because every single tissue in your body, from the top of your hair to the bottom of your feet, needs sugar to grow and to stay alive. So if they're not getting sugar because the insulin is not coming in, then you can't. Now, however, the only organ in the body that don't require insulin for sugar to get into your body, glucose, is the brain. So, but if it's not producing, then that's one aspect of insulin. And when the body cannot effectively use the insulin it produces, resulting in high circulating blood sugar or complications if not well controlled. Now, sometimes there are entities of disease that make the insulin not be able to go in, and it's called insulin resistance. So there are a couple of reasons we're going to talk about those as we move on. So diabetes has been with us for the longest time, way back 1500s, where the Egyptians wrote manuscripts about it. They talked about, two great emptying of urine. Again, we're going to talk about one of the biggest issue or symptoms of diabetes when you wake up multiple times to pee. Somebody told me today, like, oh, they have a relative who woke up up to 7, 10 times overnight to pee. And I said, listen, if you're waking up more than 3, 4 times at night to pee at any time, that's sugar. If you have any other issues like burning of the legs or whatever, that's sugar. You have to go get yourself checked. Now, the Indians also have written about it way back 400 to 500 AD, identifying the 2 types of diabetes, the type 1, type 2. And this is way back a long time ago. So it's not a new disease. But the issue that's happening now is it's on a sudden increase, a march. And why is it like that? Why is it all of a sudden it becomes a big issue, and especially in the Black community? So, okay, sorry. And then the term mellitus actually came along. It's called sweet hernia. It was done by a British surgeon. And then the Langerhans, which is the cells in the abdomen, they talked about that, was all described. So all of this has been going on way, 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 way long ago. And then Sir Harold Hemsworth described diabetes in 1936. So this is a short history of what diabetes is. If you want to know more, just go back, Google it, and you're going to read more. Now, how does diabetes occur? We have 3 main components of it. If you see the intercircle, the genetics, meaning is it inherited by parents? Does it run in families? Yes, it really does run in families. There's epigenetics. Epigenetics is how your environment, where you live, the altitude, the air, the water you drink, the type of food you eat, all of those, how it affects your DNA. Not that it changes your DNA, it affects how the DNA expresses itself, meaning how to produce things like the enzymes that your body require. And these enzymes from DNA methylation, histone, and all those other stuff. Of course, the environment, as a whole. Then we come down to obesity, aging, unhealthy diet, physical activity, and smoking. These are the ones that we can control. The other ones, we really can't control them, but the ones we can control are the physical components that has now made diabetes in our modern day time becoming the epidemic and the pandemic that is becoming too, as it is right now. So all of these put together tend to result in usually the type 2 diabetes. So what are the risk factors? Again, we talked about genetics, family, epigenetics, obesity, obesity, obesity. Big issue. We're going to see how obesity plays in the role in modern times with diabetes and where it is and where we are. Diet, food, like they said, you are what you eat, and it's a fact. It's really important. So, and that's why when they talk about diabetes, we talk about food, and what you eat. The sedentary lifestyle, a lack of exercise. This, particularly for those who are of color, we're going to talk about that a little bit as we move on, because this is how this affects us as a people, meaning Blacks or those of African descent. And I often say this: diabetes is new to the Black DNA. It is new. There were reports and documents, if you type it up, way back in Africa, where we all come from, saying, it's a continent without diabetes. In the 80s here, not too long ago. But today we have all this big issue coming up. Now, why is it like that? Because our lifestyle have changed. And I often say this: there's a reason why the fastest people on earth, both men and women, are Black. If you look around, the fastest people on earth are Black, men or women. There's a reason. It's not because we have more money to go to the gym more or have more equipment. No, it's our genetics, the way our muscles are built, and how our DNA is expressed in that respect. It's called the brown fiber or the short twitch muscle type. So if you don't move, for us as a Black folks, of people of Black African descent, because that's when your body eats up the sugar as you eat it, as you move. If you don't move, then guess what? There's excess sugar flowing around because the muscle needs to eat, and all our body is filled with basically muscle. So if the muscle stop moving, it's not eating up the sugar, especially if you're Black. And if you start eating up the sugar, guess what? The excess sugar flowing around, and that will result in diabetes. Of course, we have medications, steroids, chemotherapy, even herbs. So these are issues. Now, I had highlighted obesity earlier on, showing what the relationship between obesity and diabetes is in the United States. Now, if you look at it, in 1994, this is the obesity map, and this is the diabetes map. They kind of look alike. 2000, they look alike. And then when you go to 2015, this is what it looks like. It looks like. So as obesity matches on, diabetes is also matching on, and there's huge risk involved. Some studies have shown that people who are 90% of people who are obese have a high propensity of developing diabetes, and of course other attendant issues that come with it. Now, the unfortunate fact is from 2016 on, obesity plateaued in the US because people began to start paying attention to their weight, their diet, and all that. However, diabetes did not plateau; it's still going up. So again, it's a big issue. So it affects all races, as we know. And in 2016, the WHO and the CDC eventually came together and said, you know what, this is a big problem. It is a big problem. So they decided to say, you know what, it's an epidemic. We need to pay attention to it, and then put a white paper concerning diabetes and ensuring that everybody pay attention, and it's a big issue, not just with the US but globally. Now, what are the types? The type 1, where again, when the pancreas fails to produce, 0, and that can run in families. There's a story of a patient of mine where the girls in the family, once they turn age 13, the pancreas fails and they all become diabetic, you know. So and we've had that issues in Ronson family, and usually it can actually fail as little as a baby, 3 months old. The pancreas will fail for other reasons, multiple. Maybe we'll talk about that down the road. And then we have the type 2, which is basically which is more of the higher number of the diabetes that we have in our communities today. Now, the gestational diabetes, meaning when you're pregnant, the high increased rate of or propensity for you to be diabetic. And those has far-reaching complications as well, because once you become diabetic or you were diabetic before you got pregnant, and you have a baby who while you're diabetic during pregnancy, there are complications, heart valve problems. The babies are usually very big, and then it becomes a problem passing through the birth canal and all the other host of complications that they do come with. Then they have the type 1.5, which is the latent autoimmune diabetes of the adult. Now, if you see, for those of us who are in the medical field, we've had different nomenclatures over the years. There used to be MODY, maturity onset diabetes of the young. We don't use that anymore. Now, the type 1 is somebody who's type 2, presents exactly like type 2. You're on one medication, it's not working, 2 medications, not working, 3 medications, and then they put you on insulin. And then eventually become full-blown insulin use. That's the type 1. And that's usually autoimmune, meaning your body is producing immune components that increases the resistance of the insulin going to your body and also attacking the pancreas. So the pancreas totally fails. So you start like type 1, and then eventually the type 2 eventually end up as type 1. Now, the other one that is really big that we must talk about in our community, especially when in 2016 the CDC and WHO came together, is the entity called pre-diabetes. We never knew any, this before, but they began to realize that not everybody, one of the things that most people used to have is you're fine, everything's fine, no problem, and then boom, you wake up one morning, you're peeing a lot, or you can't see, and all that burning sensation. Most people don't know what their diabetes status is. So then they came up with the entity of pre-diabetes. You need to know what your diabetic status is. And at that stage, you know whether you have no diabetes, meaning A1C less than 5.7 or less, or it's 5.7 to 6.5 or 7, puts you at the pre-diabetes state, which is the borderline diabetes, like we say in the community. So, but anything beyond that of 7 with symptoms, then you become diabetic. Now, the bad side is this: that a lot of people, if you don't know, if there's anything you're going to take out of this today, know what your diabetes status is. Know if you are no diabetes, if you're pre-diabetic state, or if you are diabetic. Because if you're in the pre-diabetic state, on the average, it takes about 4 to 5 years from you being pre-diabetic, meaning moving from 5.7, 5.8, 5.9, 6, 6.1 to 7, on the average about 5 years. And then you become diabetic. Now, in that pre-diabetic state, unfortunately, the microvascular damages that occur in the eye, that occur in the kidney, are really taking place at that stage. So if you don't do anything about it, the changes, the damages are beginning to take place already. So that's why it's important to know what your pre-diabetic state is, so that you can begin to take steps to intervene and prevent and protect yourself. Now, these are the signs and symptoms. You're always tired, frequent urination, sudden weight loss, wound that won't heal. For men, sexual problem. For women, they have yeast and all that. Feeling always thirsty, numbness and tingling in the leg, blurring of vision, always hungry. So one of the things I realize is this: in certain families, people who have diabetes tend to present in certain signs and symptoms. That's what they get. So, and if you have any of this, it's important that, listen, you have to go get yourself checked immediately if you don't already know what your diabetes status is, because this is really important. And by the time you begin to have these symptoms, you're most likely been pre-diabetic for over 5 years or more. And the sad part is this: in the United States, it takes an average of 5 years from when you are diagnosed to when you become completely controlled. On the average, 5 years. So you can imagine if you were pre-diabetic for 5 years, and then it takes another 5 years to control, you have 10 whole years of where your sugar has not been well controlled. And that's bad, meaning 10 whole years of damages being taking place that have not been checked. So again, these are the main symptoms. We just talked about it. Diabetes, what are the number? What is statistics? Now, as it is today, 422 million people are said to have diabetes around the world. It causes about 1.5 million deaths. It's important because diabetes causes death. Now, unfortunately, we used to say, oh, diabetes is a silent, blood pressure is a silent killer. Diabetes is a silent killer because it affects every single tissue in your body, from the head down to your toes. And it's slowly until you finally hit the wall. Now, this is what it looks like, the unrelenting march of diabetes in the 1980s to 2014. You're going to see others. Now, if you look at this graph, the one with the least in 1980, like I had initially said, was Africa, 3.1%. Only 3.1% of people in Africa of a population in the billions had diabetes. But today, it's 7.1. And look at Middle East, 13. In the US, 8.3. So you can see what this is looking at from the 1980s to 2014, how the march has gone on and why it became a big issue that even the WHO and CDC recognized. Now look at this, what it is today. The rate at which it increases in different countries. Now in Africa, 111%. In South America, 85. In the US, North America, 57. And look at the Middle East, 105. 121. I mean, these are issues that are really big. So it's important that those of us who are African descent pay attention, because you see the increase of how it's gone at this level. This was 2023. At that time, there were 7.1 million people in Africa who had diabetes. Today, that has gone to about 29 million people. And in Africa, in North America, 36. And that's huge. So we begin to see how it looks like. Again, the postulation is in 2015 when this was done, they said, oh, we most likely will get 450 million people. Today it's 442, like we just said. And they at that time said there was going to be 642 million. But today I tell you, they're saying 740 million people in 2040 that will most likely have diabetes. So this is marching on. And if you're matching us, these are individuals who are being affected. It therefore means at any point in time, you either have diabetes, you know somebody have diabetes, or family member who has diabetes, and we must begin to really pay attention. Now, look at the countries with the most diabetes. Again, if you look at Africa, still very rare as compared to South America as well. But if you look at the Middle East, big issue. Diet, Western lifestyle, all of those. Now, if you look at by race, Africans are still treading behind on the last curve, this curve here. Now, if you look at all the other East Asian and everybody else, Africa is still trending, but eventually we're still going to catch up. So that's why it's important. Of course, for those of us who have African descent, we truly must begin to pay attention. Otherwise, because it's new to our DNA cannot respond or manage it properly, and we tend to have more complications than anybody else. So again, in men and women, look at what it looks like. Back in the days, women had more incidence of diabetes, but the men have overtaken the women. And today, by 2014, and that graph is even spreading far apart as well. So across the globe, in China, by year 2000, only 20 billion. By the year 2015, 98. In the US, 17. By 2015, 29.9 million. And 2017, 30. Today, it's 36 million. So you can see how the increase has been going on. For those in Jamaica, look at the numbers. Again, these are big issues. Now, just to show you the little graph that as it matches on. By the year 2040, initially they said it was going to be what? 600. Now they project 1.05 billion people by the year 2040. So you can imagine how much that has gone up really high. Now let's look at the data in the US. This is what it looks like, 38 million. And it says 1 in 5 don't even know they have diabetes. And it's so important that we must pay attention. And that's why you have to know your diabetes status. Look at what it looks like in 2004. Look at what it looked like in 2021. You see the increased coloration, especially in the not in the East Coast as well, and southeast. Again, diabetes adults, this is the prevalence. Total population 16%, white, Hispanic, and black. You see, in non-black Hispanic, 20% of us have diabetes. So you begin to see a whole lot of this. But like they always say, prevention is better than cure. Knowing your status is more important, because one of the biggest issues that we have in our community, oh, I don't want to know, because what I don't know will not kill me. Yes, it will kill you if you don't know, because it's slowly taking you away, eating you up.
Right.
You know, so we're just gonna go the complications that we have.
Dr. Aluya,
Yes,
we're going to have to wrap that up. We got quite a few questions coming in. I'd like to get to some of these questions.
okay.
So can we kind of wrap it up, and then we can, as we answer the questions, we can get, I'm sure we'll cover more
We'll talk
of this
more, right?
as we
Okay.
answer the questions.
Right.
Okay.
Okay. So, and I'll show just a few more slides so that people would know how severe this can really look. Complications, especially for us. If you look at heart, coronary artery disease, #1 cause of kidney failure in the world. One of the things I noticed that most of us are afraid of. Nobody wants to end up on dialysis. Nobody, because dialysis is a disease in itself. So, #1 cause of kidney failure in the world, diabetes. #2 cause of kidney failure in the world, high blood pressure. So if you have diabetes and high blood pressure, that's a double whammy. And this is a big issue for us as well. We'll talk about other things that makes us stroke, retinal disease, peripheral vascular disease, big issues. Now, diabetic neuropathy. 4 people get their legs amputated every day in this country based on diabetes. And it begins, the nerves are affected, and the nerves in the heart, in the brain, everywhere is affected. And that's why for some of us who are diabetic, you can have a heart attack without knowing you have a heart attack. It's called silent heart attack or painless myocardial infarction. Look at the eye. Again, one of the biggest cause of blindness, big issue. Look at what the normal eye looks like on the right, on the left, and the abnormal eye, the vision that people see. Retinal detachments, kidney disease, look at what it looks like. So economic burden cost a lot of money, a lot of money compared to around the world. Now, for those of us who are African Americans, this is what we need to pay attention to. More than 2.8 African Americans have diabetes, 1.5 diagnosed, annual number cases not known. Nobody's watching, we need to pay attention. It contributes to 25,000 deaths among African Americans in the early 90s. Far more. 7th most common cause of death in us. Look at the numbers. Extremity amputations per year. New cases of kidney damage. All of these things, blindness. This is what's happening to us in our community. So again, the numbers are there. If you live anywhere in the world, this is what it looks like if you have diabetes. Now, remember, I said Africa has less amount of diabetes than anybody else. But if you live in the US and not America, you have a 38% chance of dying as compared to if you live in South America. In Africa, 76% chance, Europe 50, and this is what it looks like. So it's important, especially if you're a person of color or of African descent, to pay attention, and you must know your status. So I think I'll stop there so far. Let's come together, manage diabetes, and make sure that diabetes stops. There are different medications that we can take on what to do and how, what to do and how to manage it. And the technology is coming up in the pipeline. We're going to talk about that, AI and all that, and all the things that we must do. So take home message, that it's a global disease. It's becoming the bane of our existence. It's much closer than we may admit. We need to understand the disease, and we must have personal responsibility for the disease. Please take care of your body. It's the only place you have to live in. And Diabetes Day, November, we pay attention. And then I have a few quotes here. Life is much sweeter without diabetes, right? Life is so much sweet when you don't have diabetes. It's no longer politically correct to just talk about diabetes. It's becoming a dutiful experience for all of us to tackle it. So thank you, and thanks, Dr. Bay, for the opportunity. God bless.
Oh, thank you. Thank you. All righty, we're back with us again. That was excellent. That was excellent. And I didn't mean to rush you through,
I
but
know, I know.
so I think we're going to answer some of these questions and get more in depth as the questions come in. Dr. Ali, there was a question that came in about gastroparesis, and I think they even tried to spell it for us, but I understand what they're talking about. Can you tell us what a diabetic gastroparesis is and why it occurs?
Sure. So gastroparesis is when there is a slowing of the motility in the stomach. So when we eat, our muscles and part of the contraction that occurs in the digestive system allows for food to get taken from the stomach into the small intestines to allow for proper digestion. The job of the stomach is it's got hydrochloric acid in it, and it breaks down the foods into its true component pieces. It breaks down proteins, it breaks down carbohydrates, and then from there it goes into the small intestine where the digestion process occurs, where things are absorbed into the body, like your fats, your proteins, your carbohydrates. In gastroparesis, there's a significant delay in emptying. So what happens is you have a stomach full of acid as well. You can get more reflux. You can feel bloated, gassy, distended. You can eat a meal, and the sensation is that you almost feel like your stomach it's like a bag of bricks in your stomach. That food just kind of stays there, and it's delayed in how it propels forward. It eventually clears and will get into the small bowel, but it just takes longer than usual, and that could lead to symptoms of nausea, sometimes vomiting. And there's degrees of this. There's a mild form of gastroparesis where people may have more milder symptoms that could be triggered by either eating a larger meal or a larger fatty meal. Sometimes it could be more severe where people cannot tolerate anything and they even need to be hospitalized to get IV fluids and things of that nature to help them to at least move things forward. So it is an end or later complication of diabetes, and unfortunately is one of those that it doesn't necessarily correlate with sugar levels, high sugar levels. Sometimes even in somebody who has very well controlled diabetes, they could still develop gastroparesis down the road.
Excellent.
Question.
Excellent.
I have a quick follow-up question to that. So
Yeah.
you mentioned that it's not just the hyperglycemia, and even in patients with well-controlled sugars, they still get complications. So and one of the things that's always been confusing for me is diabetes itself is not one disease, it's multiple different diseases and very complex. And I guess maybe Dr. Loya can help us out. Beyond just controlling the hyperglycemia, in following up with that, what exactly is the underlying issue that's causing all these problems? Because it affects every organ in the body. And beyond just control of the diabetes, patients still go on to have chronic complications. So how do we manage that?
So, as I said earlier on, if you remember, I said that, and that's why the entity called pre-diabetes came about, because we had no idea. And most of the time, for those of us who've been practicing for quite a while, the first time you see somebody when they present with symptoms. But now we begin to see people who are in the pre-diabetes state. So like I said, people can be on the average pre-diabetes state for 5 whole years, 5 years before you become fully diabetic. Now, in that pre-diabetic state, the microvascular changes that take place, meaning the nerve, because each nerve has its own blood supply, the vasa nervorum, like that's the nerve is called. It gets its own sugar to be alive. So if the sugar is not going well into the nerve, then the nerve begins to die. And those are the very first early, nerves that die. And that's why they call the autonomic nervous system complications. They call the autonomic complications of diabetes. There are about 10 of them. Gastroparesis is one of them. Painless myocardial infarction is another. Gustatory sweating, meaning you're eating, you're sweating out of the ordinary. Erectile dysfunction. And for men, the first time they go see their doctor when they find out that it's no longer working. So those issues begin to really take place in those 4 or 5 years. Now, by the time the damage is taking place and you don't pay attention to it, considering the fact that, again, on the average, between when you become diabetic to when you're actually well controlled in America, it takes another 5 years. So you have a total of 10 whole years of damage is taking place. So by the time you get to control, the damage is already done. There's nothing. Gastroparesis are setting. It's most likely going to get worse.
You know, the thing of it is that I've always tried to understand it as well, and I'm as confused as you, Kevin. That's why Dr. Aluya is so important to us. The thing of it is that the high sugars affect the nerves. Just to break it down for our audience, it affects the nerves, the blood vessels, a lot of the small blood vessels of the body, as well as some of the large blood vessels. And over time, these don't work anymore. So for instance, we were talking about diabetic gastroparesis. It's a big word, but basically it means that because of the high sugars over a long period of time, those nerves that allow the bowel to our intestines to push our food along doesn't work anymore, and the food gets stuck in the stomach and doesn't move forward. And these are some, just to break it down and just to make it plain for our public out there. That's what we're talking about, and it's not that uncommon. Dr. Anderson, you got your hand up.
Yes, guys, I'm sorry, I apologize a little late. I'm a little bit under the weather, but so Dr. Aluya, a question for you. You know, when the rubber meets the road, what are you recommending? Do we start treatment in the pre-diabetic phase? Because here's the question I have for you. We know we have young women who have Stein-Leventhal syndrome or polycystic ovarian syndrome that has anovulatory cycles, which means they have estrogen as what would happen normally in their menstrual cycle, but when they don't ovulate, that estrogen level stays high, and with recurrent cycles, it stays high, they don't ovulate. Oftentimes, we see insulin resistance in these young patients. We're talking as early as 15, 16, 17 years old, and their hemoglobin A1Cs, and I apologize again, I don't know if we have a discussion regarding hemoglobin A1C and what it means.
We have to, and I'm going to stop you right there. We have to explain hemoglobin A1C in detail so that people will understand what it means. Go ahead, Patrick, sorry.
Right. So with that measure of impending diabetes or pre-diabetes, how soon do you start to treat patients? Are you recommending that they get treatment in the pre-diabetic state, since that's when the initial, at least microvascular insult occurs?
Right. So, and I'll take it, a little further backwards first. Now, as a pediatrician, and when I see the babies that I see, especially those who are obese, I tend to screen their A1C at age 10, because like the story or the literature shows that if you're obese at age 10, you're most likely going to be obese for the rest of your life if there's no intervention. And for some of those patients that you just talked about, if you notice, a lot of them are obese as well. They usually are. And they just didn't wake up being obese at that time. The insulin resistance started way further, maybe 10 years before they got to that place. So for everybody who has in the pre-diabetic state, and what I often do is this: we'll have a plan, meal plan, exercise, everything. We'll talk about that, and then I will watch you for 3 to 6 months to see how you do with that. Are you losing weight and everything else? Now we have some meds that can help you lose weight. Now, if by 2 consecutive readings of A1C, you're still in the pre-diabetic state, then I would have discussed the options before the next intervention. Meaning, listen, we have metformin. Metformin is a great job. Great job. And it works in multiple areas. Metformin works in the brain, it works in the stomach, and it works in the pancreas. So, and it helps people lose weight. It also helps with the ovaries as well, as you all know. So it reverses a whole lot of all this things. So you have to, and that's why I always tell doctors, tell my young doctors, as a physician, you're also a salesman. You have to learn to sell your treatment to your patients, but you have to make them understand why. But you just don't throw it at them. You give options first, and then when you get to that point, they know what the option is, and they'll help you. Doc, I guess at this time, we're here. There's nothing else for us to do. I will take the metformin, and they will take the metformin. I've had to put people on metformin in the pre-diabetic state when there's no progress.
So there's a follow-up question in the chat. Can pre-diabetes be reversed? And I'm going to ask an additional question. The state is pre-diabetes a well-defined condition? Because anytime we have, precursor syndromes prior to disease processes, it's always a cutoff to what you're measuring, because it could be very tight and miss patients, or be very loose and include too many patients. So how do you respond to the 2 points, Nelson?
Well, I think that take us to another sphere where we begin to talk about epigenetics and precision medicine and racial variations in diabetic care, meaning in measuring A1C. And but before I go into that, yes, it's a pretty well defined, because that's what we do. We define entities so that we can conceive and conceptualize them, so that it makes sense to us. If you define something properly and you give guardrails to it, then it makes more sense, and you're able to work towards achieving an aim or a goal. So the 5.7 to 6 or 6.5 is what we have defined it to be. If you're in that area, you're pre-diabetic. And we also know that those microvascular changes, the blood vessels, tiny things affecting, really do take place. So yes, in that number, in 2016, there were about 88 million people who were pre-diabetic in this country. Today, that has gone up to 92 million people who are pre-diabetic. Because again, you see, people just keep moving up and all that and all that. And of course, we have a lot of people who move and migrate to the United States who had no prior encounter to the healthcare system. So all of these things are there. Yes, it helps us to determine when and how we need to intervene. But then it also gives them, the patients, put them in their mind, say, you know what, this is where I am. I need to take steps to mitigating the ill effects of what it takes place, and begin to have lifestyle changes, and if I need to take medications. Now, with A1C, studies have shown that in us, African Americans, that our A1C level are usually much higher than the rest. But I'll say this, when we talk about Blacks, and I don't want to mean, look, we're here, this is the doctor line, we have to talk like one in a kitchen table. There are Blacks, and there are Blacks. There are Blacks from continental Africa, there are Blacks who are in the diaspora, like I am right now. Now, the food I eat here, as you all and everybody know, that they are diabetogenic, meaning they increases your risk of becoming diabetic. And why is that? Because most of the food that we eat here are most likely refined, and they are pro-inflammatory. And that's why every time I check all my patients, guess what? Two things I also check as well. I check the CRP and I check the ESR. And I bet you, for those who are pre-diabetic, majority of them have an A1C, ESR, erythrocyte sedimentation, which is a sign of chronic inflammation, really, really high. On the average, no infection, nothing. They're 36 to 50, constant. And then until you begin to reduce that, the risk of you becoming diabetic in the future is so much higher. So how do you receive that? Eat more green leafy vegetables, like we say. Cut back on bread. I'm sorry, those are big issues, starchy foods, and refined sugars. You have to cut back on all of those. And down the road, and I'll show them. I say, this is where you are. This is who. This is your blood, not mine. And this is yours. So, but if you show them, mark one by one, and then say, listen, this is where we are. This is what we're going to do. In 3 months, we're going to repeat it again, and you see the A1C drops. And you see the, the ESR also drops. So these are issues. So the question is, because diabetes is new to our DNA, and the food that we eat is also new to it, and they're pro-inflammatory, is that the reason why our A1C is much more higher than everybody else? It's most likely. And like you saw the graph. If you live in the US, our percentage is much higher. If you're Black and you live in certain place, the risk of you having complication is so much more higher than everybody else.
Dr. Ali, you have your hand up.
Yeah. So, Dr. Aluya, you did a really nice job of explaining the predicament we're in, and the fact is that you're right. There's this unclear realm of pre-diabetes, and my question for you is, are we missing the mark as physicians across the country here and initiating therapy soon enough, right? So you mentioned about dietary measures, but as we see, and that's important, right? And I'll even add to the dietary measures, processed foods, refined foods definitely are pro-inflammatory. We're actually seeing that as well in the world of inflammatory bowel disease, like people who develop colitis and Crohn's, and we're seeing that more in the Black community as well, right? And I do think there is a dietary link there. But my question is, would we or should we even, if we are identify these pre-diabetic patients, should we be starting them on therapy even sooner? Right? Should they even be given a trial of something else, or would you recommend, or is it even in our guidelines to say we probably should get these patients that we identify on metformin sooner to try to negate the course altogether?
Yes, we really should. But again, nobody, especially our people, we don't like to be on meds. We really don't like medication. So it's negotiation. I have to negotiate. I have to convince you. So I said, this is where you are now. You're in a pre-diabetic state. And they're like, I don't want to take meds. Like, okay, fine. We're not going to start no meds. But this is what we're going to do. I will give you a chance in 3 months. See how you can cut bread. Cut bread. Honestly, one of the biggest, and for us, there's a story of gluten and some of these other, cereal products with the black race. There's a whole story about it. You just Google it. I don't want to go into that. And what it does to us, because again, those things are still very new to us. So you negotiate with them and say, look, 3 months from now, see if you can increase your exercise level, cut back some of this food, stop soda and all that. And then a lot of them will do, because they don't want to take so if in 3 months you see progression, meaning the A1C drops, inflammatory states drops, then you can say, okay, fine, we'll continue. But if in 3 months it hasn't, nothing's done, you now hear them say, okay, doc, I think we need to start metformin. And usually I do, 500 to 750, because the 500 is the XR, the once a day one, and the 750 the once a day one. And you'll be shocked. A lot of them have done a lot of research on those. I'm like, doc, I had so many bad things on metformin. Oh my God, it does this, it does that. I'm like, listen. And then I go online and I show them the advantage of this metformin. The risk of cancer reduces with metformin. The risk of aging, as a matter of fact, I think CDC 750 is the only one that's been shown to reduce risk of aging. Actually, it reduces the telophase phase of cell death. And those who are in the OB, you see now that they add metformin to those with repeated abortions. You understand? And those with increasing risk. So these are the issues and advantages that it really does help. And the metformin, what is really good about metformin as well, not to go a little deeper, it actually has an anti-inflammatory effect. How does it do that? It goes through what they call the PPAR gamma, which is one of the components that those who believe in cholesterol meds work on. So it does that in our GI tract. So it actually reduces the redistribution of fat in the abdomen, because the gut fat, it actually really does help. So if you start it on time, you're really going to help decrease all of those. So there's a huge advantage to that.
I'll be real quick.
This is what I'm going to do, Kev, because we have a lot of hands up and I want to get to everybody's hands. So what we're going to do, I'm going to take your question, then we're going to go to our halftime break to introduce everybody, because a lot of people came on that may not have introduced themselves, and then we're going to move forward with the hands. Okay, Kevin, you're first, and then we're just going to go through everybody's hand to get their questions answered, and then we're going to do some questions from the audience as well. Go ahead, Kevin.
So I realize we still haven't actually defined what the hemoglobin A1C is. So we need to do that for the audience and explain exactly what it is and what causes it and what the correlation with the numbers mean, and what the goals are. That's all I wanted to.
Yeah, yeah. And why why is it 90 days? You know what I mean? Understanding that it gives you an evaluation of your blood sugar over a 90-day period. And that is because hemoglobin is, of course, red blood cells. And what's the life of a red blood cell? 90 days. So it correlates. But Dr. Aluya, can you give us a little bit more refined, or even Dr. Sprock, give us a little bit more refined answer as far as hemoglobin A1C, and then we're going into our halftime break.
All right. So the average red blood cell, which is the cell, because we all have different cells. The white cell, the red blood cell. The red blood cell carries, that's the one that gives you the redness in blood that you see. And we have the white blood cell count, the white blood cell, which is the one that fights your infection. And I always explain to my patient, you have a total number of white blood cell that gives you the number. And unfortunately, a little bit of that, patients have asked me, Doc, why is my white blood cell count low? Again, that's another story. We can talk about that another time. But the red blood cell, on the average, for everybody's average, lasts about 90 days, 3 months. That's the average. And each red blood cell themselves are cells that are alive, and they carry oxygen, and they carry to your blood. So in the process of carrying oxygen to your blood, because that's the only way the brain everywhere gets blood, they also carry the food, glucose. So each red blood cell is attached to glucose, and that goes to every tissue in your body, and they go deliver it, depending on stuff, on how the body system, works. Now, the best way for us to identify how much of the sugar that's in your body within the last 3 months, because the red blood cell lasts for 3 months. So it's to measure the amount of sugar that's attached to that red blood cell. So, and that's basically what it is. And that's why when some patients come in, they won't take their medicine for a month, 2, 3 months. And they start a week to be 2 weeks before they come, they start taking it. So in the office, when you check the sugar, it's normal. Because the ideal number of blood sugar when you're fasting, is 126 milligrams per deciliter. Anything less is good. But anything less than 80 or 60, depending on your age, becomes hypo, low blood sugar, which is on its own is not good. That's another story. We can talk about that in the elderly, and over controlling diabetes in the elderly. That's another entity in itself. We could talk about that. Now, anything above 126, when you come in the office and I check, it puts you at a higher level, meaning your sugar is high. But then when you just ate and you came to see me and we're talking and I checked your sugar, anything above 220 to 240, I can consider high if you just ate within 2 hours. You understand? So that's how these things are run. So the A1C is the measure of what your sugar looks like in the last 3 months. It gives me a history because each red blood cell lasts 3 months and we measure the sugar that is attached to it. That's what the A1C is all about.
Excellent, excellent. Dr. Sprock, do you want to expand on that, or?
Yeah, I can talk a little bit about it. And so, we talk about the red cells and the red cells having a lifespan of 9 months. But over that course of time, if you think about it, the red blood cells are constantly being made and constantly being destroyed. So at the end of 90 days, you have a small percentage of red cells that are dying and a small percentage of red blood cells that are being created to replace those. And then the lifespan of all those red blood cells occur over time. And so the issue is what happens to the red blood cells when you have an elevated blood sugar. And so when you have an elevated blood sugar, then that glucose attaches to the hemoglobin, which is what carries oxygen. The glucose, as Dr. Aluya talked to, attaches to it. But the real issue, as I see it, is why is the glucose elevated in the first place? And what happens in most of the people that have elevated glucose, what tends to happen over time, especially if you correlate it with being overweight and obese, is that under normal circumstances, when you eat and you're eating carbohydrates are sugars and starches, they get absorbed and they then get created into glucose, and then it goes up. But with a small elevation in that glucose, when you eat, insulin is released, and insulin recognizes that the blood sugar is getting elevated, and it keeps it under the normal range. And so most people, under normal circumstances, they take carbohydrates, the blood sugar goes up, but the blood sugar never goes above normal because insulin is released right as it starts to see an increase in the bloodstream. But what tends to happen if you start to become overweight, there's something that they title it insulin resistance. And I'm not sure if that's the actual correct term, but what tends to happen is that in order to keep the blood sugar under normal levels, the amount of insulin that the pancreas has to release is larger, and it takes a longer period of time. Instead of it keeping it in check for minutes, it may have to be twice as much insulin is being released, and it might not be able to get the blood sugar down for hours. And the more obese you get, then the more insulin that you have to make. And at a certain point, even though your pancreas is putting out lots of insulin, it's still not able to keep the glucose under control. So what does that actually mean? Well, what it means is that your pancreas is making lots of insulin, and a lot of the medications that you're given forces the pancreas to make even more insulin. So for me, the issue is, in terms of you have someone that comes in that may be pre-diabetic, and yes, you can talk about trying to do something and cut out bread. I think that the issue is that you not only ought to get them to cut down on their carbohydrate intake, because the other types of calories, proteins and fats, don't cause you to release insulin. It's only the carbohydrates. So my view is that one of the things that helps, and people, is Dr. Jordan, is he on?
I think he's on, but
but one of the things that we found out in certain individuals who were very, very obese and who had type 2 diabetes, if they had surgeries that really restricted their ability to take in any calories due to surgery to cause them to have weight loss, as these individuals start to lose weight, some of them, all of a sudden, were no longer diabetic. And so for me, the key to one of these issues is not just to talk about cutting out bread, but to focus on cutting out the calories that they're taking from all carbohydrates, and to see, as a result of that, weight loss, reduction in weight loss, which might improve the ability of the insulin that they're already overproducing to work better. And so I think that one of the things that for people that there's no medication that doesn't have any kind of side effects and don't want to take medicine, if you could get them to lose weight and to focus on their weight loss through caloric reduction, specifically reducing the carbohydrates, you might not have to go on medicine, or you might reduce the amount of medicine that you get. But the key ought to be that you lose enough weight so that your insulin starts to work better, and you no longer have this long period of time where it takes to get your blood sugar back to normal, and you start to have less amount of insulin being released in order to control it. Mm-hmm. And so the issue is again, if I can, Nelson, you can argue with me if you want, but if someone comes in that's, I'll say, 250 pounds, and they ought to be, under normal circumstances, 120 pounds, and they've cut out bread, okay? And they come back in and they're still 220 pounds, my guess is they haven't accomplished a whole lot, okay? They may have done something, but they haven't accomplished a whole lot. If that same individuals could lose 20 pounds, and I don't want to get into the issue of Wegovy and Ozempic and the weight loss things, because everyone's looking for a quick fix. They're looking for these medicines to cause them to cause weight. When the real issue is we need to dramatically alter the foods that we take, especially the amount of carbohydrates that we take. If you already see that they're having a problem because their body's making too much insulin and their blood sugars are going up and the hemoglobin A1C is elevated. And so just like it takes a while for the hemoglobin A1Cs to go down, the reason it will go down is if the blood sugars aren't up. And the key to not having the blood sugars go up, I think, is trying to alter your diet, especially the carbohydrates, the starches, and the sugars.
Excellent. You know, and we're going to go to our halftime right now, but just to piggyback on that, I've always been told that pre-diabetes, if you lose weight, decrease your carbs and sugar, and exercise, decreasing carbs and sugars, and losing weight, then potentially pre-diabetes is curable. That's what I've been always. That's what I've read in the literature in the past. But we're going to
just one point about the exercise. Mm-hmm. Understand that when you exercise, your muscles require energy, and they will utilize some of the glucose. But if you're talking about someone that has glucose in the 200 range, exercise isn't going to do a whole lot to dramatically decrease it. And right. So the issue is you need to be very, very focused on caloric reduction and exercise. Right. But you can't say, well, yeah, you're gonna exercise for half an hour and you're gonna drop your blood sugar by 20 points. No.
Even with weight loss, exercise is only about 20%.
That's
of
correct.
The whole component. So it's what you eat and the amounts that you eat of what you eat is the most important thing. Let's do this. Patrick is off. Hopefully he'll come back on real quick. But Dr. Court, can you introduce yourself, please?
James Court. I practice in East Orange, New Jersey. My specialty is adult medicine.
All righty. Dr. Aluya, please.
Yeah, Nelson Aluya, a medical advocate. Always good to be here as always. Thank you.
Definitely. And we're happy you're here too, brother. Dr. Aluya. Excuse me, Dr. Ali.
Hi, Dr. Mazhar Ali, gastroenterology, Scripps Clinic, San Diego.
Excellent. And Dr. Sprott, please.
Kenny Sprott. I'm a retired pediatrician. I spent my career in academic pediatrics and did 15 years of critical care pediatrics as well as general pediatrics.
Excellent. Excellent. Dr. Clark.
Dr. Kevin Clark. I'm a surgical oncologist at Beth Israel.
Excellent. And I'm Dr. Omar Bey, pulmonary critical care and the subspecialty in nutrition. Let me just say that as far as the webinar, it's every second Saturday. Please note at 1 o'clock. Please have family, friends, church members, everybody. Let them know that they can sign on and ask their medical questions. And we are going to get to the medical questions. Don't think I've forgotten you. If you want to view our past webinars, please go to obhealthy.com, all one word, hit the YouTube sign, and you can view all of our past webinars. Number 3 is please do not change any aspect of your medical care until you consult your physician, no matter what we say, because everyone's different. We all are different. And when we think about medically, and only your doctor truly can take care of you from a medical standpoint. I'd like to thank OBHealthy for allowing us to bring this platform to you. And let's get this going again. I have a question here, and just let me know if anybody has any information. It says, oh, well, we covered that. I'm sorry. There was a question about Splenda. And if you took 1 Splenda or 2 Splendas a day, maybe in your coffee or your tea, would that be harmful? That was the question. Can anybody gravitate to that question and give us some indication? The way I look at it as a physician, and there are many things that we eat, and and the body is a wonderful unit that takes care of itself. 1 Splenda a day, I can, from the way I look at it, 1 Splenda a day shouldn't really not hurt you over the long period of time. All righty. But if someone else has any consideration or anything to say about that, please step up.
Well, I often say this, that you can see your physician and spend the maximum, when you have your annual well, 30 minutes. And then other times 15. And that's what, the insurance or whatever, allocates for you. But you're with yourself 247. And considering the fact that as us as human beings, we're very complex and everybody is very different with variations. And sometimes I use the analogy, you eat an egg, you're fine, and then nothing happens. But I eat an egg, I end up in the ICU. Does that mean eggs are bad? No, it's just bad for me. So the question is, if you take a Splenda, and you're diabetic, and you see your sugars, keep rising up and all that, then probably you shouldn't. Maybe Splenda is not good for you. You can look for alternatives. But if you are able to maintain your sugar, you're able to exercise, do your calorie count, and see your doctors regularly, check what your A1C is. You have no symptoms, fine. You could do that, and live well. I often tell people this: you're not living for diabetes, you're living for yourself, and that's the primary essence of what life is all about. And sometimes people get so consumed with with their disease that they forget to live. And that's why it's important that you sit with your primary doctor and have an objective, rational discussion of what your plan that suits you to be like, and not like somebody else or taking somebody else's medicine. And that's what I would say. Thank you.
Right. Dr. Ali, did you have something to say about it?
Yeah, so one a day for me that's not a big deal or a concern, but when people take a lot, one of the things that can happen to the GI system, it can give you diarrhea as a side effect. Some of the artificial sweeteners can do that.
Excellent, excellent. Dr. Anderson, we went through introducing ourselves. Can you come on and introduce yourself, please?
Yes, I apologize. I got kind of called away to a situation at the hospital. But I'm Pat Anderson. I'm a GYN oncologist. I take care of women's cancer. I work at Newark Beth Israel. I was trained and influenced by some of the men on these panels, and I'm always happy to be on this program.
Thank you, brother. Dr. Court, your hand is up.
Yeah, a long time. I have a question for Dr. Louis. First of all, I practically use the same methods in terms of educating patient about prediabetes. And the simplest one that works for me is to tell the patient, look, don't put no sugars in your tea or coffee. That tends to work. It goes directly to them. I don't know what else that you use in terms of having them become interested in watching their pre-diabetes stage to move on to full diabetic. The other question I have, I don't know what studies were done to show there's a correlation between elevated cell rate and uncontrolled diabetes.
Yeah, to your first question, again, I'll have to sit and I discuss with them. What's the greatest meal that you consume that has more sugar? And a lot of them will tell you it's the bread. I eat bread every day, every day, sometimes twice a day. And we know, again, I did allude to what wheat has done to us as a people. And then if your sugars are high, you're the pre-diabetes state, and we have talked from within a month to 3 months and say, hey, okay, cut back on the amount of bread that you eat, cut back on the amount of rice that you eat. And for those who are Africans, cut back on the fufu, or use the size of your hand as a measure. You understand? And if you want to eat rice, then half rice, half beans, or half rice, half quinoa, or however you want to do it, or add more vegetables to it. Yes, that tends to really help. And a lot of them would really confess, like, Doc, I think it's the bread. And they'll tell you because they know they live with themselves. And you see, all right, fine, cut the bread. You can do it instead of doing it every day. You can do it 3 times a week or twice a week. And then, of course, exercise. I did say how important exercise is to us as Black people. Like I earlier said when I my presentation, there's a reason why the fastest people on earth, men or women, are Black. It's our genetics. the short twitch muscle fibers, or the brown fibers that they call it, makes us eat more of the sugar when we move our muscles, just on a plain level. And that's why it's so important to actually do exercise. And that's why if you look around now, even in Africa, with the pictures that I showed you all, and those of us who are here who left Africa 500 years ago, the more sedentary lifestyle that we have, the worse our diabetes is. And that's basically the fact. Now, coming back to your chronic inflammatory state, it's something I actually use as an adjunct to helping me manage my diabetes. So if you come see me for the first time, I check, it's usually very high. And I'll show you. And if you look, the acute inflammatory marker, which is the CRP, if you have an infection right now, it goes up. And then the chronic one, it's usually low. But the ESR is usually high. And then we'll talk, and then we use it as a marker. So down 3 months, 6 months, if you check, it really goes down as well. So that chronic inflammatory state that we are puts us at risk. Now, one other issue that we also fail to forget and discuss, especially those of us who are Black, vitamin D, big time, big time. In Africa, if you look at Africa, the people who were not dealing with diabetes, as a matter of fact, I trained in Nigeria, and by the time I practiced and left Nigeria, I barely saw diabetes. I really did. But right now, big issue. What has changed? The Western lifestyle, sedentary lifestyle, the diet, and then lack of activity. Because the more activity you have, the more outside you are. So when you're outside, you tend to have vitamin D. Big issue. And for those who are Black, we were told that, oh, early morning sun is what you get to make your vitamin D for. But look, we now know that it's not the early morning sun for us. It's usually, midday, sun because of our melanin. So we make more vitamin D then. And vitamin D has been shown, and I correlate that as well, that the higher your vitamin D level is, the less your ESR is. And I've looked at that. Why? Because vitamin D has it reduces the intrinsic inflammatory effect and upregulates your innate immunity. And that's why most people who do that have a higher vitamin D level, other than the fact that it helps with your celebration and all that, also help in controlling your sugar. We've seen that in women who are pregnant, where studies show that those with less vitamin D during pregnancy tend to have a higher risk of gestational diabetes. Clear. All of these things are really important as well. Vitamin D level, huge in our community.
Doctor, we are on the same page because I tell the patient, really, if you use 4 slices of bread, cut it to 2. If you use this much rice, cut it in half, and it works.
There's a comment on the chat that some of the terms that we're using, medical terms, may be not, some folks may not understand it. So if we can explain some of it.
Omar, you're on mute.
I was wondering where I was. Thank you. All righty. The thing of it is that this is what we're going to do. I know I have several hands up, Dr. Sprott and Dr. Patrick Anderson.
Right.
Let's keep our questions and our statements kind of short and explain it quickly. What we need is to answer some of these questions, and we have a lot of them to answer. Dr. Sprott, go ahead, please.
Yeah, I think one of them was, and I don't know if it was covered because I came late, about stress. And one of the things that's been associated with stress is elevation of corticosteroids or steroids, which is a hormone that's made by the adrenal gland, which sits above the kidney. And steroids have historically been known to raise the blood sugar levels. So there is a possible correlation between individuals that undergo a lot of stress, having elevated steroids, and then having elevated blood sugars as a result of that. And one of the things that was also talked about are artificial sweeteners, and there are all sorts of different kinds of things. Splenda being one, and the issue is, and it's important that people read what they are. Stevia it comes from a leaf and it's sweet, and the Splenda, and you'll see things that say sucralose. Almost any word that ends in OSE is a sugar, but that's something that's sweet, but it's not so absorbable. And Dr. Mazur talked about things like sucralose, and if you take a lot of sucralose, that can lead to diabetes, not diabetes, to diarrhea, because it doesn't get absorbed so greatly, stays in the gut, obligates water, and increases the water content of your stool. So if you're going to use these things as sugar substitutes and use lots of it, then you may have some of the side effects as it relates to that. But you might not have as elevated blood sugar as you would if you were using either cane sugar or the fructose comes from corn syrup or things like that.
All right, excellent. Patrick.
Yeah, so just to add to the dietary thing, we need to also pay attention to condiments, things like salad dressing, ketchup, mayonnaise, those kind of things. When we speak about, not putting sugar in your tea or in eating 2 slices of bread instead of 4. So I just want to comment on that. And then the other thing is, Dr. Aluya, what about the use of supplements? There's some anecdotes that talk about the use of burpene, the use of cinnamon, the use of chromium to help manage blood sugar.
Yeah, if you notice, most of those things are anti-inflammatory, so they tend to reduce the pro-inflammatory state that we have. And who knows, there are a whole lot of elemental things that happen at the mental level that we haven't really investigated, or research hasn't been done for them. Maybe cadmium help reduce the insulin resistance. Maybe it does that. But some of the ones we've known, like I gave you an example for metformin, what it does to the stomach and the PPAR gamma and all the other things. And then it actually has a GLP, like effect as well. And that's why metformin will give you nausea, easy satiety, like the Ozempic or the other ones. It helps you lose weight as well. So these are the other things. And the ironic thing is, as you gain weight, with all the redistribution of fat in the stomach, the DPP4, those are components, that helps with absorption at the elemental level of sugar in your system, are denatured because there are also enzymes that help break those things down. So maybe cadmium and cinnamon help inhibit those enzymes that break the DPP4. You understand? So these are how things happen on elemental level. But the ones we know, yes, the ones we really do talk about.
All righty. Dr. Sprout, please.
Yeah, one of the things, people like things that are sweet. And even though cinnamon isn't sweet, it has a tendency to be added to a number of desserts. And so it might be able to decrease the amount of sugar that you use. There are also some studies that suggest that cinnamon may play a role in slowing down the speed with which certain sugars get absorbed. And so if it decreases the speed with which it gets absorbed, it decreases I'll say the spikes that you get, especially from those types of sugars that are readily absorbed. When people had diabetes, especially in children that took insulin and then they became hypoglycemic, which means that their blood sugars fell real low. You always say, well, take a sugar pill or you take some orange juice, because that rapidly gets absorbed from the stomach and gets into the blood. And so if cinnamon delays sort of that absorption of glucose or slows it down, then that might keep things from getting these high spikes. And remember that when we talked about hemoglobin A1C being related to glucose elevations, if the glucose isn't so elevated, then you won't need as much to keep it in check. So there are some other things, and again, supplements that are antioxidants and things that are anti-inflammatory or things that may be helpful, and not just with diabetes, but with other things like your brain and your gut. And so these supplements And one of the things about supplements that is troublesome is that very often they aren't as well studied. My belief is that because the pharmaceutical companies are responsible for a lot of the money that goes into biomedical research, and these pharmaceutical companies can't make a whole lot of money off of supplements. And so there aren't as many studies, but there are people that are increasingly studying some of the uses of supplements and what they might be used for and what might be beneficial. And so I would say that if there's something that you think may be helpful, and there's a website that's the government sort of sponsors called PubMed, PUBMEG. And if there's a supplement that you think might be useful for something, you put that into the search, and it'll give you any articles that have been written, scientifically peer-reviewed articles that might have been written, both in animals and in humans, if there have been studies in them, that might lead you into a direction as to what might be helpful for some of the conditions that you might have.
Give us that website again.
It's PubMed, PUBMED. It's NIH or the government sponsored, and it's free. And so almost anything you can think of, if you're interested in it, diabetes, Alzheimer's, ulcers, depression, anything you can think of, they'll have studies on it, and it's it's not supported by pharmaceutical companies, so it's fairly objective.
Excellent.
So just
Excellent.
to clarify, pubmed.gov, not com.
Oh, sorry about that. Yeah, when the government puts something on, they use the GOV at the end of it. So it's just, if you just put in PubMed, then it'll come up.
All righty. Excellent.
So,
Excellent.
I want to say something with regards to supplements. Before you start anything, first and foremost, know what your kidney function looks like. Know what your liver function looks like. Because anything you eat is broken down in the liver and excreted in the urine. So know what your status is. So when you start, in another 3 months, you gotta go check. Because I've seen people who started supplements and the liver failed and the kidney failed. So because you don't know where these things are coming from, you'll be shocked that websites will tell you, oh, it's in the backyard of here in Los Angeles. Meanwhile, it's done in somewhere in Vietnam. You gotta be careful with those stuff. So and if you have to do anything, you have to know that it's something from a trusted site. But like I said earlier on, everything is not good for everybody. You just have to know yourself and know how it works for you. Like
Right.
I give the analogy of the eggs. Eggs are not bad, but it can be bad for some people.
And also let me piggyback on that. If as far as natural medicine is concerned, and vitamins and things like that, sometimes a person may say, well, if a little bit is good, a lot may be better. But understand, everything has a side effect. No matter what you do, if you take more than the prescribed amount, you're setting yourself up for a risk of having side effects from that particular element that you're taking. All righty.
Just on that note, and piggyback on Nelson's, the leading cause of liver failure in this country is due to acetaminophen, which is the ingredient that's taken for pain. It doesn't have any anti-inflammatory effect, and a lot of the pain and discomfort associated with a lot of illnesses is really inflammation. And so, and people will take Tylenol, acetaminophen for pain. Doesn't help. They take more and they take more, and then they end up with liver failure. And so, again, you shouldn't be taking things that your doctor doesn't advise you to take, and certainly you shouldn't be taking in amounts greater than what's recommended.
What's prescribed. Excellent. Excellent. Let's get to some questions. Can you reverse the damage of type 2 diabetes? Yeah, I know it's a big question, but
yes, I'll tell you this. It's for a short answer, mostly no. And like I said earlier on, if you're in the pre-diabetic state and you saw the picture of where the nerve is damaged, and nerves, some of them, majority of them never recover once they're damaged. And that's how it stays. But if the damage is mild, you can actually help slow the progression of the disease or prevent the progression of the disease, depending on what your genetics is made of, really. Because some people heal faster, some people don't. And some people's nerves heal faster and some people don't. So the primary essence is one, know what your status is, intervene when you have to, exercise, especially if you're Black, watch what you eat because we are what we eat. And you can help stop the progression of diabetes or even reverse it by taking those steps.
Dr. Sprout.
Yeah, part of the damage that occurs from elevated blood sugars over time is really to the very, very small vessels. And these very, very small vessels supply oxygen from the blood to nerves and to small arteries and to the walls of blood vessels. And so the question as to whether or not it's reversible or repairable, I think is related to how long you've had it and how much damage has been done. There are some, one of the things that if you have diabetes and you go to your doctor will usually try and see whether or not you have any injury to your nerves, especially at the periphery. And so they might do a little tone thing that they hit something and they put it on your toe or they put it on a bone. And they'll ask you whether or not you feel that tingling sensation with that tuning fork. And then they'll say when it goes away and then how long that goes. There's been some suggestion that if you have, some deficits in your nerves in the extremities, that's measurable in terms of that, how long it takes for that your sensation to go away before it goes. That if you are able to reduce your hemoglobin A1C, then there may be some improvement in your ability to feel that tone over time, which may be suggestive that there is a possibility of either the delay or the return of some function that might exist. And so in my mind, if that's possible with what's happening with nerves, it might be possible that the same thing may be happening with other small vessels. And so when you talk about the issues of leading to blindness or leading to a coronary artery disease or even injury that might lead to strokes, there's no question that I think that it may not be able to reverse things that have gone, certainly if you've lost the limb, there's no replacing the limb, at least in this day and age. But the ability to get it under control that might prevent further advancement or further damage that goes on is something that you ought to consider. And with some individuals, they're concerned about, as you age, your spouse and maybe having to take care of them and things like that. And so it becomes important to keep in mind that not only are you doing it for yourself, but you also are doing it for your family. And you are becoming interdependent or more dependent on other folks over time. And so it's always a good idea to try and get these things under control. And as I said before, I think the key is in trying to deal with weight loss and a reduction. One of the questions that was there dealt with intermittent fasting and one of the benefits of intermittent fasting. And one of the whole issue of intermittent fasting is that you limit your food intake to maybe an 8-hour time frame. And that means for the other 16 hours, you don't have any kind of food intake. So if you don't have any food intake for those 16 hours, you can't really have any increased spikes in your sugar because you're not taking in things. And so if you're gonna do the intermittent fasting, not only won't you have that, because your body needs energy, in order to get energy when you don't have that glucose that's readily available, because you can't store glucose for more than about 8 hours or so. And most people, after an overnight fast, will have exhausted the liver storage of glucose. And so you will start to break down fat and also break down some proteins. And the breakdown of proteins might not be so good, but a lot of people don't mind the breakdown of fat that occurs. And so this issue of intermittent fasting is a way that maybe you can decrease the amount of glucose that you have, and also increase the amount of time that your body is utilizing stored glucose as well as breaking down fat cells. And so it's not something that that everyone can do or stick to. But I think that if you're going to do it, there are some advantages to it, and there are different methods that you can use. But the key, I think, would be to, if you're going to do intermittent fasting, limit your food intake to 8 hours, let's say from 10 to 4 or something like that. You don't eat anything after 5. Might have some benefits with reflux too when you go to sleep. But the deal would be to try and moderate, decrease the amount of carbohydrates that you have when you do that, and that might be very beneficial to you over time.
Excellent. Dr. Clark, your hand's up.
So I think really what we're talking about is slowing the progression down, or trying to halt it, but not really reversing. And correct me if I'm wrong, even in patients who have perfect control of their blood sugars, there is still progression that's not preventable over time. Is that a correct statement, or am I wrong in that?
Yes. In fact, I actually spoke to a lady today. It's like climbing up the hill. You know, by the time you take time to climb the hill, the sugar is up, the A1C is up, and then you get to a point when, you know, in the process of climbing the hill, the microvascular changes, the inflammatory changes that occur with those small vessels are already in place. So by the time you get to the hill and your A1C is coming down and you're protecting it, well, guess what? The damage has been set on roll already. So they will go on to progress at least for a short while. And then probably with exercise, with, you know, intervention and everything else, you may now stem it or stop it so that it doesn't progress even more to a point where you now get your leg amputated. And one of the things that I also do, and we have begun to, you know, correlate this, and because again, as a medical advocate, one of the things I do, I see the prevailing, you know, technologies that's out there, and then see how it apply to our people. Not too long ago, maybe Dr. Cart would, you know, would know of this. There's a huge push to do, you know, ABIs and screen for ABIs and all that. But a lot of people looked at it at the financial benefits of it. However, there are other benefits that come out of it, because you can use that as to preempt the vessels that are looking down, you know, down your legs, to also preempt what the vessels in your heart can look like in the future. So when you do your ABI, the narrowing of those vessels, and I've seen somewhere over the years, you do maybe 2019, the ideal number should be anything above 1, right? When the ABI is the ankle breakout process to measure the pressure within the arm and measure the pressure within the leg and look at the flow as blood flows in. It's a comparative analysis. And once you do that, a lot of the time, for those who are uncontrolled, I've seen as well that the number initially may be 1.24, which is really high, meaning the vessels are really open, the flow is good, but over time they begin to narrow to a point where it's 1 and then less than 1. Because I'll tell you this, like I said earlier on, 4 people get their legs amputated due to diabetes every day in this country. But nobody wakes up and gets their leg amputated. It begins with something. And the way of measuring what that looks like is a measuring the amount of slowness and the narrowing of those blood vessels within the leg. And it can also predict that of the heart as well. So if you see that, then you begin to intervene. You know, maybe put them on high cholesterol medicine, making sure that their A1C is well controlled, making sure that their blood pressure is well controlled. Because if you have high blood pressure and diabetes, the rate of deterioration of cells is even faster. So doing all of those is a combination of things so that you can now show objectively to patients, like, listen, this is where you are, and this is where you are yesterday, but if you do this, this is where you're going to be tomorrow. Because anything less than 1 is concerning, but when it drops down to 1 to less than 0.7, 0.7, that becomes critical. And those are individuals who have higher risk of amputation. So these are some of the things we need to teach and be aware of as we speak and measure and manage our diabetic patients.
Excellent.
Doc-
Excellent.
Doctor, what I see quite often, the insurance companies send their people out to the patients' homes, and I see results for ABIs all the time. But most times when you feel the pulse, the patient usually has a good pulse. But I usually refer them to the vascular surgeon in terms of what really that means, because most times the pulse is there,
Mhm.
and the ABI, to me, the result is not correct.
Right.
But it's
The pulse
always
will be
done by the insurance company.
right. The pulse may be there. Last year it was 1.24. Today is 1, and that's a significant change in what's going on. So it's imperative, like you said, you get them to see the vascular, and if you catch them well on time, you stem the progression of that to a point where it becomes critical, less than 0.7. And there are medications you can use to intervene, but the most important thing is exercise, 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 and controlling
Right.
your sugar.
Yeah, I'm glad you said exercise, 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 because I think that none of these things are just isolated in and of themselves. And so I think that as we age, we sometimes get lazy. And there's a great deal of muscle atrophy that can occur if you don't exercise and you don't try and maintain your strength. And the benefits of maintaining your strength will also increase your balance, which can prevent you from falls, which can lead to your death. And so a lot of these things are related. And so part of the question is, with these ABIs, which, and you talk about the ankle brachial, measurements that sort of lead to blood flow. I'm not sure, how often insurance covers it or how many times they'll do it. There's certain things that are screening tests that don't necessarily, they only let you get so many before you have to pay for it yourself. But I think the issue is how important, or how might exercise modify some of this stuff. Certainly, I would think that if you are walking a certain distance every way, that may be helpful. If you're doing strength training, especially with your lower extremity, that may be helpful. And that may, I certainly know that those muscles are requiring blood flow and oxygen, and that might help. And so I think there are lots of things that may be helpful that certainly shouldn't be harmful. You should never exercise that you're experiencing pain, but a lot of these things may be helpful. And certainly, if you have a blood sugar that's under normal control, and now they're doing lots of different things where you are measuring the blood sugar constantly, where their insulin's being released that have better control over it. But I think that some of the damage that's there may be reversible, some of it may not be, but certainly your goal ought to be to live as good a potential for a healthy quality of life. And that means trying to keep yourself fit, healthy, your brain fit and healthy. Exercising and diet becomes more and more important.
Excellent. Dr. Anderson.
Yeah, I think, we're talking about diabetes, and we're talking about hyperglycemia, or elevated blood sugar, as it occurs in a manner that's seemingly natural based on lifestyle and day-to-day practices. One of the categories that we need to be mindful of is what we call iatrogenic, or elevated sugar that occurs as a result of treatments that some of us are also recommending for patients, right? So, for example, some of the cancer patients, part of their therapeutic regimen includes steroids. Some of the collagen vascular disorders like lupus and so on requires the use of steroids. Some autoimmune diseases that affect the liver and the kidney requires the use of steroids. And as Dr. Spratt had mentioned before, these steroids often elevate blood sugar. So we have to keep an eye on those and kind of gingerly toe the line as to how much to give to mitigate the effects that we don't want, and how much to pull back to manage blood sugars, and then what to add in conjunction with your therapies to manage blood sugar. So some of these things are need to be considered. Nelson, I don't know if you want to comment on that.
Yes, you're right. As a matter of fact, in my previous world, when I had a grant, HRSA grant to manage sickle cell at university, I was also managing primary care cancer patients. And one of the things that one of the machineries I put in place was when a lot of my patients pre them starting chemotherapy, because chemotherapy is huge in itself, can burn up the pancreas, and of course with steroids increase the risk of you becoming diabetic. Is I'll screen you completely, know what your diabetic status is, know what your kidney status is, and even know what your heart EF looks like, ejection fraction, meaning the power of your heart. So we do that before they actually start the chemo. So when they start the chemo and anything happens, they come with leg swelling, A1C that was 5.5 is now 6.5 or 6.2. We begin to measure it, you understand, and then keep an eye on it over time. Now, for those whose A1C continue to progressively go high, I would just put them on metformin just to stem that or reverse that. Now, for those who've had chemo, they also come, sometimes one of the very first early symptoms they come, they're like, oh, doc, I feel nerve burning. My nerves are burning in my legs. Is it diabetes? A lot of the time I look at the chemo that they had, it may actually be the chemo that results, like cisplatin and all that can actually affect the nerves. So, but then we screen for the diabetes as well, but we anticipate that they will get there to a point of diabetes. So we put them on meds and continue to monitor them. Yes, you're right. It's something we need to pay attention to. And of course, like you said earlier on, pregnant women as well, big issue in our community. And in the elderly, I don't know if there's a question of diabetes in the elderly. Maybe we'll talk about that later. Over controlling sugar in the elderly has a detrimental effect, and a lot of them come down. There's a huge number of people who die, but they usually die from a cardiac infarction, and that's another story. If we have time, we'll talk about that.
Dr. Sprock, your hand is up.
Yeah, piggybacking on Nelson's suggestion about drugs, and I think Dr. Mazar has said it before, is that something that works well for one person is fine, but that same drug can have a side effect that is 1 in 1,000 or 1 in 10,000. And so this is an anecdote, but my brother-in-law who's been on statins for a number of years, his doctor changed his statin and his blood sugar went sky high. And the only thing that he had changed was this one statin for another statin. And as soon and his doctor didn't know what was going on, but the PA looked it up and said, hey, this has been noted to have this. And when he stopped it, his blood sugar came back to normal. So, you need to be careful about, when you are starting on a new medication, just because, and people, have been trying to get me to start taking statins for 15 years now, and I've been resistant, because a lot of people have issues with their muscles. And then they said a small chance of liver damage and a small chance of kidney damage. And I said, I like my muscles, I like my kidneys, I like my liver. Even if it's a small chance, if I get it, it's 100%. So I've been resistant. But I think that just because 95% of people may not have a side effect, you may happen to have the side effect. And unless you're aware that, I mean, the level of hyperglycemia was just astronomical, and he really didn't have much in the way of symptoms. And then he went and had blood work done, they said it was elevated. So you always need to sort of be aware that there may be changes that may occur. It could be a supplement or it could be a prescribed medication. You need to make sure that medication may not be causing an adverse event in your life.
Mm-hmm.
Yeah, and one of the things I think we should think about is when we look to define folks who are at risk for diabetes, Dr. Luya mentioned the obese parent. Just remember, when we talk about parents, we're talking about a group of people that we're defined as young, right? So the obese parent, the parent who are pre-diabetic, and he as a pediatrician, Dr. Spratt as a pediatrician, now look at that child, and is that child obese? And when to start looking at the hemoglobin A1C. Another at-risk group that we need to think about is gestational diabetes or diabetes in pregnancy, because that's probably one of the most important predictor of which young woman will become diabetic or pre-diabetic even before they get to the age of 40.
You know, Anderson, the rule of thumb was if a child has one parent that's obese, it's a 50% chance of that child being obese. If both parents are obese, it's over 75%. And so there's a correlation. And you've seen families like this where everyone is overweight and obese. And there's no question that if you are obese as an adolescent, you start to, it's one of the things that you look for and you check for. Nelson sees so many adults, so he doesn't see any. He doesn't like to talk about the fact that he has a background in pediatrics. But yeah, you start to look at hemoglobin A1Cs in overweight adolescents because there's definitely an increase in type 2 diabetes in that group.
Right.
So real quick, Omar. So Kevin, you may be more knowledgeable about this than the rest of us. The whole idea of bariatric surgery and the reversal of some of these seemingly chronic illnesses like hypertension and diabetes. Can you quickly talk about that?
I mean, well, to be honest with you, I know the phenomenon works, exactly the mechanism. I'm not sure. And I'm not sure I mean, besides it being a restrictive and a malabsorptive procedure where you actually lose weight, there's some idea that there may be some physiology as far as hormones and things that happen to facilitate that. But I'm certainly not an expert. Beyond telling you that it's a restrictive and malabsorptive procedure, that's where my level of expertise ends.
Maybe we need Dr. Garrison back.
That would be right. That would be a question for Dr. Garrison. You're so right.
I think, like I had said earlier on, other than the fact that one, it constricts the amount that you take, but we also know that the way the new medications work is in the GI tract. The DPP-4 and the GLP-1s are basically in the GI tract, the stomach. And as obese as you are, the larger the surface area of that intestine, the small and the large intestine especially. So by the time you reduce that component of it, now there are other chemicals I alluded to that are produced when you get to a certain, BMI level, let me say. And they are—
Explain BMI, Nelson.
Body mass index, meaning the size of your body compared to your height.
You are.
So, and there are other chemicals, again, like they're neurohumoral, there are enzymes, it's a whole lot of complex, issues. So there are things that, fasting the way the GLP-1s are broken down, and there are others that increase the way that DPP-4 are produced. So all of those things in itself, it's a combination of things that once you cut back on that tissue expander in the abdomen, reduces the risk of your A1C and all the other stuff.
Right. There are a few questions that we should get to before. There's one that says, do any of the doctors have recommendations for CGMs to help monitor blood sugar levels and spikes? So I guess these are products that regulate the blood sugar. Do you have any comments on them, or which would be better, or which products are better?
Right. I think those are the Libre Freestyle Libre and the Dexcom 6, and now they have the Dexcom 10 that you put underneath the skin. They just help you monitor your sugar. And then the first thing is they don't have to prick themselves that much anymore, which is great because most people don't check because they don't. And because of that, they just feel they're fighting a losing battle. And that battle, the failure of that battle begins here. And once it fails here, everything else fails. So with that, a few of my patients, what I see is they pay more attention to it. It's easy to read. And then it's calibrated in such a way that if you get to a certain level, it begins to beep. It beeps so that you can watch what you eat and how you eat. And God forbid, your blood sugar drops as well. It tells you all of those. So which one is better? the Freestyle Libre came out in the company in the market really early. It was so damn expensive, nobody can afford it. Now the Dexcom came and it's improving. So hopefully the cost will come down to a point where the average man can buy it and everybody can use it.
Yeah, I mean, I
Excellent.
think these continuous glucose monitoring addresses a behavioral component to dietary intake.
Right.
And it also addresses knowledge of nutrition. So if you're hungry and your sugar is low, yes, I can take a little bit more carbohydrate. Well, what is a carbohydrate? We talk about breads and rice and potatoes and simple sugars that relative to if I'm hungry, should I take something that's more fibrous, like a chunk of broccoli, some green salad, but also helps you decide, well, on that salad, do I add a little bit of honey mustard dressing or a little bit of Italian, which is more vinegary and less sweet. So I think that helps more with behavior modification and lifestyle modification than anything else.
Yeah.
So Patrick, you asked about the bariatric surgery. I saw an article that looked at 400 individuals that had the bariatric surgery, and after 6 years, 62% of them had no signs of diabetes, compared to individuals that had just used medications or management, only 6%. So there, you know, and again, one of the things that happens is that as you have the surgery, you're dramatically reducing your caloric intake because there's a mechanical stricture that prevents you from eating large meals. But they also encourage you to monitor your diet, to exercise, and then as the BMI, the body mass index, falls, which is they look at your height, they look at your weight to see whether or not it's proportional or not. If you have weight that's a lot greater than what your height is, your BMI is elevated. Then it starts to come down. They try and get it below 30 or whatever. They saw that these individuals needed less medication, and then at a certain point didn't need any medication to control their blood sugar. So,
and it's
one of the
interesting.
things we have realized also, though, there's quite a few patients who, after they've had the surgery, have regained the weight.
Yes.
And to a significant point where they're not at where they were before, but the weight loss that they've had, they've regained a significant portion. I don't know what happened to their diabetes at that point, if they had to be put back on medication, or if that effect was sustained or not. And that's one of the interesting questions to look at.
So
I think the whole
Go ahead,
issue of
Dr. Mazur. Hold on, Dr. Mazur. Then you, Patrick.
Oh, one of the interesting things that I think we may even see a little bit of a shift from the surgery, right? So surgery obviously invokes the weight loss, but now we've got this whole new wave of medications that have come out that I wonder what's going to happen in this shift with things like Ozempic, Mounjaro. These are some newer medications that are actually designed. What they do is they slow down the stomach emptying. They induce a gastroparesis into the stomach and allows people to have early satiety where they get full quicker. So I'm wondering, and as this new wave of medications come in, the question as well is how relevant will surgery be, not now for patients who have a BMI greater than 40 or morbid obesity, then surgery is probably going to be the right answer here. But I think that we're going to see a little bit of a shift in how we practice in the future with these medications.
We've already seen that already. The market share or the numbers of surgery have gone down. But is that sustainable? And these medications, I mean, bariatric surgery has been around for quite a while now. The medications have just started to be used. So there's always a question of long-term results and durability too.
Dr. Mazur, what's the monthly cost of Ozempic or Endura?
You know what? I'm not sure, but it's prohibitive.
You're not sure?
It's up there.
About 1,200.
It's not. It's
general, I think
thousands of dollars a month.
Yeah, well, I think that you can get, good RX or something to reduce it, but you're talking about $1,000 a month, which is $12,000 a year. Right. And that's, as I said before, there's some, I'll say lack of objectivity when you have these folks that are advertising for the use of these drugs and saying, oh, they're dancing in the streets and they're having weight loss and they're doing all this other stuff. And you know, they don't really, and again, you know, not for nothing, Zantac, when it came out, was supposed to be great for, you know, and now it's off the market because it causes cancer. You know, we don't know what the long-term use of this stuff, because you can't stop taking it. That's the problem.
That's the thing.
Certainly, if you have the bariatric surgery, you know, it might be expensive to do, but then if you don't take Ozempic, then that's 12,000 a year savings.
Now, let me correct myself. I'm not advocating for it.
No, I'm not saying that you are, but I'm just saying that, you know.
I think what we will see, though, and what I'm interested to see, is the shift of where we're going to see our data as it comes in. I do think that it's making an impact, and we're starting to see more weight loss medications come into the marketplace, right? And now they're coming in and they're very cost prohibitive. But let's say a decade from now, right? How will this make an impact? And I think it will.
Well, here's what I can say. I don't think that I've seen any pharmaceutical companies make recommendations for bariatric surgery. And in 20 years, I still won't see pharmaceutical companies making recommendations for bariatric surgery. And so I think that, you know, they're not objective in terms of what the ultimate outcome is, other than profit for shareholders. So you know, I think that there may be an impact, but when you look at the dollars and cents, you know, it may be better, because if the diabetes can certainly go away, these medications aren't curing diabetes.
Well, you know, I think when it comes to all of this, what it comes down to is understanding what drives the intake of food. And when you go to counsel someone regarding bariatric surgery, and while I'm not a bariatric surgeon, I happen to know that psychiatric evaluation is part of the preparation, right? Because and there are several weight loss programs that are now highlighting, you know, the psychology of food intake. And it's not that this is new, because here's the thing: when fast food come on and talk about supersize it, or the different meats they put on a sandwich, and how big their sandwiches, and the cost of a footlong and all that, what that's telling you is you can consume more efficiently and cheaper. And now we have DoorDash. So there is no intermittent fasting between the time you order and the time you consume. It's there in 15 minutes. So at the end of the day, the psychology of food intake is being manipulated to allow you, or encourage you, to consume more, in spite of the use of the GLP-1s and all this other stuff to restrict gastric emptying and reducing the size of the stomach and all of that. So it's like it's counterintuitive.
You know, you look at this stuff, you know, they have it, it's all scientific. They know the combination between sugar, salt, and fat.
Right.
Okay.
And the color of the food.
They manipulate those things. You look at the calories in a Cinnabon.
Right.
You know, it's like, you know, they put this stuff in, and hey, it's not so cheap anymore. The cost of fast foods has gone up with and DoorDash adds to that cost. You know, it costs $40 for a family afford to eat at McDonald's.
And here's the thing: we just talk about the potential role of cinnamon in helping reduce blood sugar, and you just mentioned in one word, Cinnabon. A bun is usually,
you know how much butter and how much sugar
is in that bun. You know the thing. I'll tell you this. We need to understand the politics and the economics that drive, you know, even research and the utilization of food and medicine and everything else. Like you all saw in the graph or the pictures that I showed earlier on, the onset of diabetes as a raging bull from the 80s. And we know what happened in the 80s when, you know, what do you call it, simplified or purified sugar was introduced into our system. And out of that, this is where we are now. And all of a sudden, diabetes is here. Now also with these GLP-1s, I've had at least 15 years of experience with GLP-1s. The GLP-1s that first came out, the Byetta, the exenatide, but it wasn't widely used As a matter of fact, Victoza first came out, which is the daily dose, and everything else, and Trulicity and all the other ones that people lose. It was so very expensive. But then when social media and Hollywood got into the picture, it blew out of proportion. Now it's cosmetics or whatever, but the science of it still remains the way it is. Now, the data, as more people are using it, the data will come. Personally, what I've seen, because I've been using it for over 10 years or 15 years with a lot of my patients, those who stay on it, they do well. The sugar's down, the control, there's reduced risk of hypoglycemia because it actually works when you eat. And that's how GLP-1s are produced. It's an analog. So the risk of hypoglycemia is so much less. However, a few of the people who stopped it gained back the weight and they had to go back on it. And that's what I've seen. Now, with the reports coming up, and if you remember when I said GLP-1s, metformin act like GLP-1s, and metformin has been used in reproductive medicine and all that. What are they saying now with the GLP-1s, Ozempic? Those who are taking the Ozempic are now finding that, oh, they're getting more pregnant even when they're on the Ozempic and on what do you call it, a birth control. It seems like the birth controls are failing, but because again, that's the adverse reaction, and these are some of the things we're going to see as we move on. There'll be other things that are coming up. I did show the technologies that are in the way coming up. You know, the 5Gs and the AI combination with what do you call it, quantum physics and all the other stuff combination. Maybe another day we'll talk about that as a topic in itself, what the future is looking at as we combine technology and medicine.
Hey, Nelson, have they changed the way that people get pregnant?
No, they still get pregnant. But the question is, what's the outcome of those babies? That's another story.
You know, in wrapping up, and I just like to say psychologic and with weight loss and everything, you know, there are only so many things that we can control in life. You know, you may not be able to control, you know, what job you have. You may not be able to control many, many things that come at you every day. But the one thing you can control is what you put in your mouth,
Correct.
what you eat. And that pleasure center, for some people, and they, you know, there's a component of research out there that feels that the obesity is driven by a pleasure center in our brains. And if that's a component of it, then we have to consider that as well. Why does one person over here, his metabolic rate is popping and he's able to utilize all of the calories that he puts in and not store as many. Whereas the other guy next to him, if he eats one meal a day, he's storing 80% of it, you know? So there's so many dynamics that are involved with weight and how weight relates to secondary diseases like diabetes and hypertension and all of that. And it really gets complex. And I talk to my patients often and say that the body works as a unit. You can't have one, you know, if you have kidney problem, well, guess what? That's affecting all of the body. It's just not the kidney that's sick. The whole body is sick. And when you're talking about being obese and overweight and diabetes, and you said it, Dr. Aluya, that it affects the whole body. So the greatest thing about this is that we are developing new medications that may have significant effect in a positive way. What's going to happen down in the future? What are the side effects or complications? That's just going to play out as time goes on. But the fact that we have them and that we're starting to use them, and hopefully the price will come down so that more people will use them and we will get a volume of research that can really tell us exactly what's going on. That's exciting. That's exciting to me that we're moving forward in that direction. As we sum up, is there any last words that we'd like to say about diabetes or anything before we sum up?
Yeah, I'm going to transition from diabetes to Dr. Omar Bey. For those of you that don't know, Dr. Omar Bey is transition from his private practice into retirement. He was
Not
honored.
not total. Omar.
Well, I'm just saying he was
Can't
honored
help
by
himself.
the Medical Association for all of the work that he's done over the years in terms of providing medical information and nutrition advice, and is the genesis of this program here. So I'd like to thank Omar for all that he's done and welcome him to the world of the retirement, even though it's not entirely well-deserved the rest. You can see all those framed diplomas and accolades behind him, but I'd like to thank him for having done all that he's done over all the years, and enjoy your retirement.
And I can
let's call it
honestly say,
pre-retirement.
I can
Call it
honestly say,
pre-retirement, not retirement.
pre-retirement. I can honestly say, coming from the mouth of Dr. Spratt, through Kevin, Nelson, Dr. Ali and myself, what was important for me over the years, and I think my brothers can speak to this, is the mentoring. I think what we're doing here, and here comes Dr. Court again. The mentoring is so important because there are times in medical school when we feel like, the work is difficult and we need encouragement. There they were. When we feel like the system is against us, there they were to say, listen, pull up, as Booker T. Washington would say, pull up your boots by the bootstraps. When we think that, the system was unfair to us, they simply said, listen, you think it's unfair, you just get a better grade. And here we are today. So, as much as the community in general benefit from both of you guys, the work you've done, the information and how you disseminate information, the role modeling, it was so key to the rest of us.
I ditto that 100% because I leaned on Dr. Sprock so much coming through, and he was always there for me. So even him saying this today, he's my mentor. So I got to I just got to give you all the praise and I wouldn't be here without you. So 110%.
Well, thank
Yes.
you all.
Dr.
Yes.
Court, bro,
Yeah.
we'll certainly miss you. We'll certainly miss those Saturday mornings gathering in the doctor's lounge. There were two of us who meet around the same
We're not
time.
retiring from that.
But
He retired from
no,
practice.
no, I'm retiring.
Yeah.
Let's clear this up. Let's clear this
Come on,
up.
bro.
I'm
We need you.
retiring. I'm retiring from the pulmonary critical care aspect of my practice, and
Well,
that's
well,
true.
well, that's the issue I have with it, because for Kevin and I, who do these crazy operations, patients come out sicker than they go in, and we need to bring them back from the brink. When we disagree with what's going on in the unit, doesn't matter what time of night it is, we would call Omar and say, Omar, this is the data. What do you think? And either he would agree with what they're doing, or I would say, listen, I asked him to try some other things, or why don't you guys do these things, and we would listen to Omar, and more often than not, it would be very helpful. So is that part of it? I don't know that he won't be able to deliver the way he did. He just won't have the hands-on, and I'm going to miss that.
Yeah, I understand, but I'll be there. I'm still in the ICU every morning making rounds. It's just from a nutritional standpoint right now, as opposed to a critical care. But my hand is still in the ICU making rounds and making recommendations. And if you have a question, I'll give you my opinion. I'm not sure exactly, you know what I mean?
How it will change
how it's going to change things, but I will always have an opinion. That's for sure. And hopefully it will assist you in the future. I'm not gone. I'm still around. Okay. And
I mean, if I may add to that, echoing what they've all said, thank you so much, Dr. Omar Bey, for your leadership, for your care, and mentorship and everything else, and for giving this opportunity to us to be able to give back to our community the knowledge that we have. I don't see anywhere else where you have Black men in medicine coming together like this every Saturday to deliver this. This is one of its kind, and we're reaching out to people all in South Africa, Nigeria. I see some of the people in Nigeria and all the other places and everywhere else who turned in, and they've been here for the last 2.5 hours, and appreciating this. It's how we give back. As we do that, we appreciate each and every one of them as well who come on every time to do this, and those who who are not here right now. And I'm sure they wish to be, but doctors' lives are often busy. But one of the things we're trying to do here, two things. One, to engage our community, inform and educate them, as well as empower them on their medical knowledge and their rights, and also create advocates out of what each and every one of them do as well, to stand in the gap for us to do our work better and do what they do better in their individual spaces, because that's how a community moves on. And my last word on diabetes, first, have a primary care doctor. If you don't have one, you have to have one, because it makes a lot of difference. You're going to have somebody who will sit with you, go through your labs, your medications, and know that everything's different from your brother or your sister, even from your uncle as well. Even if you share the same gene, check your diabetes status. Know where you are. Are you diabetic, pre-diabetic, or not? Make sure they check your kidney. Make sure you check your what do you call it? Your heart. Make sure they know that your liver are functioning well. You don't have any adverse reaction to any of the medications and all that. So these are the things you ought to know, and your blood pressure is well controlled. You're watching your weight, and then exercising. And these are the things that will really help you to achieve and attain optimal health, because without that, it's really hard. One will protect the other, and together we'll protect our community. And I'll leave you like that. Thank you once again.
Okay, then. Excellent. We're gonna end up with just me having a few words. Number one, our next webinar, and I think you stated very clearly optimal health. I'd just like to talk about just a very plain, and get an understanding for everybody about how to pick a doctor. What about insurances? What about genetics? But just basic stuff that we as a people should know, as far as how do we keep ourselves healthy. And I think that's going to be our next webinar. Now, understand that August is our vacation month. So next month, everyone gets a chance to cool out on that second Saturday, because we're going to take August off. September, we will be back. And I just like to have a general conversation about good health and how do we move forward with it? How do we pick a doctor? If you have a doctor, are you sharing it with others? Is the doctor attentive to what you need? Are you getting the tests that you should be getting for the disease entity that you may have? We need to put forth our knowledge from a physician standpoint, or I should say physicians of African descent, and what we feel that you should do when you come into a difficult situation as far as interacting with a physician or hospital staff, or how do you move forward to keep yourself healthy. All of these things are important from our perspective, that all of the audience out there is getting what they need. So just understand, September, we're going to all come and we're just going to talk about medicine from a perspective that we can help you navigate this. It's a difficult navigation, but we're going to help you navigate, and ability to get better as far as health is concerned. All right. I'm going to end right there, and we ran over just a little bit, but it was worth it. And thank you, each and every one of you. Let's just end with, I would like to thank OBHealthy for letting us, bringing this platform to you. Remember, it's every second Saturday at 1 o'clock. Just come on to Zoom and, be a part of us. OBHealthy.com, hit the doctors tab and come in and introduce yourselves and put that question in. Caring and sharing. Let others know about what we do here, because as Dr. Aluya said, listen, we come and we just want to educate our people about health, because it means so much to us. The most important thing that I could say, if I don't say anything today, is don't change any aspect of your medical care until you consult your doc. Only your private physician can truly take care of you from a medical standpoint. Until September, I'm going to say peace, and I had a wonderful time today with all you brothers. It's so great to have you. I'm looking forward to September, and we're going to rock and roll one more time. All right, peace, everyone.
Amen. Peace.